Good morning, everyone. I'm Val. I am a current neurology resident and mom, and I'm making these videos to hopefully learn some neurology, hopefully provide some inspiration for those of you who want to pursue neurology residency or residency in general. I like to learn neurology, of course, and I also like to learn about other mothers who are in residency. Right now, I am filming this while my baby is sleeping and before I go to work. I want to just share little snippets of different topics in neurology as I learn and to hopefully help somebody out there learn as well. I'd also love to talk about topics of motherhood and residency, kind of balancing that out, um, pumping during residency. So, just a variety of different topics. But for today, we'll just talk about a topic of neurology and none other than stroke for today. The things that, as a neurologist, you have to be well versed in because you can really make a difference in somebody's life if you catch a stroke early. So we'll just jump right into it, okay? So, what is a stroke? So, a stroke is a disruption in the blood supply to one of the vessels in our brain. So, our brain has a lot of blood vessels. We have large arteries, small little arteries that feed our brain tissue so that our brain can do its job. And when there's a disruption in the vascular supply, so it could be whether the blood supply has stopped in that case, that would be considered an ischemic stroke. Something has blocked the blood vessel from flowing, from getting that blood flow to the desired area of the brain, or what we call a hemorrhagic stroke, which is when there's a rupture of a blood vessel, and so that blood vessel just leaks out the blood that it's supposed to take to the designated area in the brain. And hemorrhagic and ischemic strokes are the two main strokes. Hemorrhagic is a lot less common than ischemic. Ischemic stroke makes a large majority of the strokes that we see. Um, and timing is important. So, we'll talk a little bit about how to recognize a stroke, but the timing of when the symptoms started. So, a lot of times, strokes will cause clinical symptoms. And there's a new category of strokes out there that are called clinically silent strokes because some patients come in and we see on their imaging that they had a stroke, whether it was in the past or somewhat recent, and they don't remember having any difference in their symptoms and in their ability to move or their sensation. And so I think it's a new category that's up and coming, called clinically silent strokes, where the patient never felt anything and yet their brain imaging shows that they've had some sort of attack in their brain. In neurology, we like to think of what is the etiology of the stroke. So, what caused the stroke? Yes, it was an ischemic stroke, or yes, it was a hemorrhagic stroke, but why? Why was there a stroke in the first place? So, this might be a little technical, and I think this video can be geared toward the general public just for educational purposes, as well as for other residents or medical students that are interested in learning neurology or just about strokes. But there is something called the TOAST criteria or TOAST classification of etiologies of a stroke. And we can start with small vessel, that's one of the common ones. And as the name says, small vessel refers to one of the small vessels in our brain got blocked or possibly ruptured, but most likely blocked. There's also one of the very common ones is a large artery atherosclerosis, so referring to the larger vessels in our brain. That could be the vessels inside the cranium or the vessels along the neck, so your carotids as well. Um, and then there's a cardioembolic, which is a tricky one somewhat, but it makes up also a large majority of the strokes that we see, and sometimes it's not caught until later. Um, we normally do a certain type of workup for a stroke, and we'll kind of go into that in another video. But essentially, there's different types of workup that is done after a stroke happens for our patients, so that we can figure out why it occurred and what can we do to prevent a future stroke from happening again. Um, and then other classifications include stroke due to another determined source, which encompasses a wide variety of things, but it can include hypercoagulable states such as cancer, antiphospholipid syndrome, whether we think it's two processes that are happening and we just don't quite know which one would have caused it, maybe both, or it's still to be determined what would have caused the stroke. Within those classifications of etiologies, there's other things that could happen, like embolic stroke of unknown source. So maybe we know there was an embolus that had to have happened to block the vessel. We just don't know where that embolus came from. And so our job is to figure that out. And sometimes it's not necessarily done all in the acute setting because some of these things take a while. And then the other one is cryptogenic. So we say cryptogenic to result. Just to glaze over the 5 different etiologies that are considered under the TOES criteria for stroke. Next, timing of a stroke is very, very important. And I will go through in another video how we approach what we think is an acute stroke, because acute refers to the timing of the stroke. There's acute, there's subacute, and then there's chronic. And so as a neurology resident, we are trained to be able to respond to an acute stroke within a timely fashion. It's very important. But we also want to educate the general public and the people that we take care of to know how to recognize a stroke, because if you're out with your friends or out at a family gathering and you see that somebody has this, you want to be able to recognize it and get help as soon as possible, because treatment depends on the timing. So, in the timing of the onset of the clinical symptoms. We're very evidence-based focused. We like to keep up with the trials in neurology, especially within vascular neurology. That way we know what to do clinically, how to best help our patients. So, we think about, okay, when somebody comes into the hospital for a stroke, and let's say it's a stroke that we're concerned happened fairly recently, or what would be considered an acute stroke, then we want to ask the patient right away, or the family member that was with the patient, when was the last time the patient was normal or did not have these symptoms that you are concerned about for which a stroke was called? When was the last time the patient was normal? So we call that the last known well. And the last known well helps to tell us, okay, is this patient going to be a candidate for our treatment options? Which one is thrombolysis? Okay, we put an agent through an IV and helps to bust the clot, per se. So we want to see if the patient is going to be eligible for that. There are new guidelines coming out that are working to extend that window that we currently work with, but it also depends on other imaging findings that are seen, and I'll go into that later. But essentially, it's been known for a long time within the 4.5 hour window is generally when it would be appropriate to give what we call TNK, amongst other factors that are taken into that decision. It's not just the timing, but that's a big part of it. So timing is very important, like I said, in a stroke. Now, it's important to recognize that for a stroke, it's a clinical diagnosis. So what that means is if somebody comes in, there's concern about a stroke. The reason we're concerned about a stroke is because they had a change in their function, in their ability to move, or their ability to sense, their sensation, or their vision, or their speech. There was a clinical change that happened, and that is why we're concerned for a stroke. There are times where imaging, because and I'll go into this a little bit more, but we generally get imaging to help confirm if there was a stroke. But sometimes the imaging doesn't show anything. Sometimes it's what we call negative, or maybe it's too small for us to see on the imaging. And we can't necessarily say that there was not a stroke. Even if the imaging isn't clear or doesn't show something obvious to us. And so it's important to recognize that a stroke is a clinical diagnosis, but imaging can definitely help confirm things, and it can even give us a little more information on the time when a stroke might have occurred. So there is such thing as MRI negative strokes that happen, just FYI. Now, talking about imaging, next thing is usually when somebody is, we're concerned about a stroke or they came into the hospital to get stroke workup, there are 2 or 3 big pieces of imaging that we like to get. The very first one is a CT head without contrast. And what that tells us in the acute setting, we get it because we want to rule out if there's any hemorrhage, any bleed going on. Like I said, there are hemorrhagic strokes or strokes that are due to bleeding of a blood vessel. And in that case, we do not want to give thrombolytic agents that are going to cause someone to bleed even more. And so we essentially want to rule out hemorrhage in the brain. Okay, that's number one. Now, a CT head without contrast is not great for seeing ischemic strokes, especially those that are new, acute ischemic strokes. Now, on a CT head without contrast, you may see an old stroke, very well defined old stroke. Usually older strokes that are more chronic, they appear dark, pretty dark on a CT head without contrast. And so you can tell, oh, it's an older stroke. When it's a newer stroke, you typically don't see it. You can sometimes see some lack of a gray white matter differentiation is what we call it, but it's just very hard to see overall, and especially if it's a smaller stroke. So we don't use CT head without contrast to rule out an ischemic stroke. We use it to determine if there was hemorrhage, and if there's something subacute or chronic that may have happened, an ischemic stroke that is subacute or chronic, you may see that. But do not use it. It's not the best to determine if there was an ischemic stroke that just happened. Okay, so once we have ruled out that there is no bleeding, then the next step is, okay, well, we need to, one, look at the blood vessels, because sometimes the blood vessels can show us if there is a clot. So the next thing that we do is we get a CT angiogram of the head and of the neck, because we're looking at the blood vessels to see if there is any clot, any blockage in one of them. We can also see if there's a lot of atherosclerosis or just stenosis or buildup of plaque in the blood vessels. And that helps us because if somebody has a lot of plaque in their vessels, then we can kind of start to deduce, okay, maybe this was due to a plaque breaking off and clotting one of the vessels. So it's important to get that imaging right then whenever you're concerned about an acute stroke, because it can be intervened on. Vascular sometimes is brought in if we think that one of the neck vessels or larger vessels is worthy of an intervention. We like to get that. And usually a lot of these treatments are also time-based. So we need to act within a certain window to be able to maximize benefit of that intervention. And so that's why time matters. It's all about how much benefit has been seen, has been shown in the literature. So that is CT. Now the last thing is MRI, magnetic resonance imaging. Very helpful and sensitive in determining if somebody had an acute stroke. Of course, you'll be able to see old strokes as well, but we care to know about the acute new stroke. If somebody comes to the hospital for concern of stroke, we want to know, was there a stroke? But like I said, there are times, less often, but there are times when we don't see anything on imaging. It could be that it was too small to even see. That does happen. Now, I say this in the context of we all have to have good clinical judgment. Maybe somebody has symptoms of a stroke, but it was actually something else. Or it could be something that we call recrudescence of an old stroke. So somebody has an old stroke and they have symptoms that may have been similar to their first stroke. They have an old stroke on imaging and it's consistent with the side that you would expect things to be on. That could be something we call recrudescence, not necessarily that there's a new stroke. But that's a different topic, and it's just one of the things you need to consider when somebody comes in with a stroke. I'm going to have some coffee. So good. Okay. Now, we talked about why time matters a little bit, and like I said, at the end of the day, a lot of the treatment options that we have are dependent on the time because and we ask ourselves, like, why does that matter? Well, a lot of the studies that are out there, a lot of the research that has been done, it is time based, and so we don't have other things to look to. We don't know if something's going to work for something if it wasn't tested, and so that's why we stick to different times, because adverse effects and maximize benefit for a treatment. And so we stick to the evidence that we have that shows benefit. Have to be evaluated for every person. Okay. Now I'm just going to go over this really briefly. So the first one is balance. A sudden loss of coordination or your ability to walk, that's concerning. Okay. Especially if it's somebody who's otherwise healthy and just going about their day and they suddenly lose their ability to walk or to walk in a straight line or to coordinate their movements, that's concerning, okay? Eyes. So a sudden change in vision, whether that be double vision or blurred vision, or you just see a complete black covering your visual field, that's concerning. Next is face. We look for facial asymmetry, or if there's a droop on one side of the face that's not seen on the other, keep an eye out on that. Next is arms. Of course, if you lose strength in one arm, the other one is otherwise healthy. Keep an eye out on that. Speech out from these treatment options. Well, it depends on timing. Treatment is not all benign. There can be negative consequences of the treatment itself, and we want to minimize. And I'll go into all of the contraindications to TNK in another video, but those are things that are very important to consider. And how we are going to chat about the FAST mnemonic and recognizing a stroke. We can include BEFAST in here too. Next is any changes in speech, whether it's slurred or you can't find the right words all of a sudden. I said, if you bring somebody to the hospital because you're concerned for a stroke, then you want to try to keep an eye on when did you first note the symptoms that you're concerned about, whether it's for yourself or whether it's for somebody else. You want to know, okay, when did I first notice this in my loved one? That way we have a more accurate idea of when these symptoms might have started. Okay? So that's a little bit of an overview about stroke. Thank you guys for sticking around. I will be making a few more videos as time allows. I'd love to chat a little bit more about just different topics in neurology, as well as other topics regarding motherhood and residency. I think that's a huge topic that I'm personally interested in, and just balancing that. And hopefully that'll help somebody else out. If not, that's okay. Then that can be a sign of a stroke. And lastly is time. So stick around if you're interested. Thanks for watching, and I'll see you in the next one. Bye.